Hello, this is Dr. Brooke Patterson, and today I want to talk to you about the head, neck, ears, eyes, nose, and throat. When thinking about the muscles of the neck, knowing these locations can help you distinguish the location of the thyroid gland, specific lymph nodes, and the major veins and arteries. The two that are most helpful to me in terms of landmarks are the sternocleidomastoid muscle and the trapezius muscle. This is a picture of the great vessels of the neck highlighting both the internal and external jugular veins, carotid artery, and others. You can also visualize the sternocleidomastoid muscle and how the carotid artery runs in front of this muscle, the internal jugular vein just under this muscle, and the external jugular vein on top of the muscle. While we will not be practicing palpating the thyroid gland, as this is an advanced practice technique, I do want you to be familiar with its location. It is located just under the cricoid cartilage of the neck, surrounds the trachea, and is just above the sternal notch. The lymph nodes of the neck will also overlap with our knowledge of the peripheral vascular and lymphatic system, but I really like this picture of the neck and the corresponding locations of the lymph nodes in relation to the muscles. Common or concerning symptoms include swollen lymph nodes, lumps in the neck, enlarged thyroid gland, hoarseness, headaches, or traumatic brain injuries and/or concussions. I wanted to mention hyperthyroidism and hypothyroidism here in the health history because these two conditions affect nearly every system in the body, and you will pick up on many of the symptoms in the health history. You will notice in hyperthyroidism that in general the symptoms represent the body speeding up in some way. For example, nervousness, increased metabolic rate leading to weight loss, which causes excessive sweating and heat intolerance, increased heart rate and palpitations, frequent bowel movements and/or diarrhea, and muscle weakness. However, with hypothyroidism, you will notice that these processes will slow down. You will see a combination of fatigue, weight gain, dry skin, possible cold intolerance, edema, constipation, weakness, or muscle cramps and other neurological symptoms. This slide also points out signs of hyperthyroidism and hypothyroidism, but these are more objective signs that are found on a physical exam. When starting our physical exam, we will start off with inspection. We will look at all the skin on the scalp, face, and neck, and we will note if we see any masses or scars, redness or scaling, or any other skin findings. We will observe the hair and note the quantity, distribution, and texture, and note if there is any hair loss present. We will evaluate for facial and tracheal symmetry, facial expressions, and paying attention to any involuntary movements. The picture on the left is an example of what mixed edema could look like in severe hypothyroidism, and on the right is a picture of parotid gland enlargement, sometimes seen in mumps and is also a commonly infected area in the older adult population, which can be life-threatening and is known as parotitis. This question asks, which of the following symptoms is not characteristic of hyperthyroidism? A, hoarseness, B, intolerance to cold, C, palpitations, or D, constipation? The answer is C, palpitations. Hoarseness, intolerance to cold, and constipation are commonly seen in hypothyroidism. Palpitations may be seen in hyperthyroidism. When asking about a patient's eye history, we need to ask about their last eye exam, if they have a history of color blindness or have ever taken a color blindness test, if they use glasses or contacts, if they wear hard or soft lenses, and how they care for them. The most common visual acuity testing in a primary care setting is the Snelling eye chart that tests for distal vision. You ask the patient to cover one eye with an index card or their hand and read the smallest line and repeat with the other eye. You will report these findings as a fraction, with the top part reflecting the distance the patient is from the chart over the distance a normal eye can read the chart. You also need to understand the difference between presbyopia and myopia. Presbyopia often occurs in older adults and is when it becomes difficult to read words due to them being blurry and is measured via other testing. Myopia is what is measured via the Snelling chart and is the patient's inability to see from further away. I wanted to provide you with these two pictures just as a review of the structures of the eye. When we are looking at the eyes, you will notice the position and alignment. We've talked about hyperthyroidism and hypothyroidism, specifically Graves' disease. You will see an abnormal protrusion of the eyes. Scaliness of the eyebrows can indicate a condition called seborrheic dermatitis. You will inspect the eyelids for any edema, noting if you see any lesions or redness or the presence of any discharge. I just wanted to point out a few variations and abnormalities of the eyelids. On the left, you will see ptosis of the left eye, which is also known as drooping. On the right, you will see an example of what I mentioned in the previous slide, with the protrusion of the eyes, which occurs with exophthalmos in Graves' disease or hypothyroidism. The picture on the left is an example of a hordeolum or stye, and the right is an example of a chalazion. This question asks, the decreasing of vision acuity associated with aging is called A. Presbyopia, B. Hyperopia, C. Myopia, or D. Diplopia. The answer is A. Presbyopia. Presbyopia refers to the loss of near vision related to aging. Hyperopia is farsightedness, myopia is nearsightedness, and diplopia refers to double vision. A normal sclera should be white. This is also the area where you would see any jaundice or erythema. Redness of the sclera may indicate allergies or infections such as conjunctivitis versus a subconjunctival hemorrhage that you would see in the right lower picture. A subconjunctival hemorrhage is common, especially in patients who are on anticoagulants. When we examine the pupils, we will check to see if the left and right pupils are equal, round, reactive to light, and accommodate. If any of these findings are abnormal, it will likely signify a neurological abnormality or could also be a side effect of a medication. Convergence is a normal finding when someone is focusing on a near object. This question asks, this condition is a common cause of poor central vision among the elderly that may include either drusen or wet exudate. It is A. Glaucoma, B. Macular degeneration, C. Presbyopia, or D. Retinal detachment. The answer is B. Macular degeneration. Macular degeneration is an important cause of poor central vision in the elderly. There are two types, dry and wet. Prevention is the #1 health promotion activity when it comes to head injuries and involves many safety measures. The leading cause of traumatic brain injuries are falls. They also can occur due to motor vehicle accidents or being hit or struck by an object. It may be important to review a patient's medications because this is a leading cause of falls. Taking a look at the home environment and avoiding the use of throw rugs, the removal of extension cords, and clutter are important to preventing falls. Also, encouraging our patients not to text and drive, wearing seatbelts and helmets are also important preventative measures. When recording the findings of a physical eye exam, you will record the patient's vision and acuity measurements, if applicable, extraocular movements, drainage with description if present, and color of sclera, conjunctiva, and lids if applicable. When acquiring the health history of the ears, it is important to ask questions related to hearing loss, questions that can determine if the hearing loss is conductive versus sensory neural, ear pain, history of ear discharge, tinnitus, or vertigo. If any of these in the review of systems are positive, you will follow up with old cart questions to elicit more specific and descriptive findings. I like this picture because I think it's a good visual to distinguish between conductive and sensory neural hearing loss. Conductive hearing loss occurs when sound conduction is impeded through the external ear, middle ear, or both. Sensory neural, however, occurs when there is an issue with the pathway interfering with the transmission to the cochlear nerve. You can also have a situation where a patient has both conductive and sensory neural hearing loss. This is often referred to as mixed. As with any abnormal findings in the review of systems, you will continue with old cart to gather further information if any of the questions are a yes. You ask about rhinorrhea, the type of discharge, any type of congestion, medications, recent infections, epistaxis, and change of smell. This is a picture of a normal mouth and pharynx. You will notice that the mucous membranes are pink and moist, which is a normal finding. You would notice that in a patient who was dehydrated that the mucous membranes would be dry. In this picture, you can visualize the hard and soft palates, uvula, tonsils, and the back of the tongue. When obtaining the health history of the mouth and pharynx, you want to ask if there has been a history of any recent upper respiratory infections, a history of strep throat or recurrent strep throat, sore throat, hoarseness, a sore tongue or history of tongue lesions, bleeding gums or gingivitis, tooth pain, and dysphagia. If dysphagia is present, we also need to ask about any particular foods that would be affecting the ability to swallow. You can see an example of herpes simplex and its involvement in the external area around the mouth and lips. These typically present as vesicles, but then will drain and crust over. The right is an example of angioedema, which can occur in an anaphylactic reaction or potentially the use of an ACE inhibitor such as lisinopril. When conducting a physical exam of the ear, you will note any deformities, lumps, or skin lesions or discharge. Movement of the pinna and tragus will be painful in otitis externa. You inspect the nose with a pen light and inspect the inside of the nose, observing the nasal mucosa, noting the color of the mucosa and any other abnormalities if present. As previously mentioned when viewing the area around the mouth and lips, in addition to edema and lesions, you will note the color of the lips, which can be indicative of an issue with oxygenation, especially if more of a bluish color. You will look at the oral mucosa and note if the area is moist or dry, if any ulcers, nodules, or white patches are seen. White patches may be indicative of oral candidiasis. You also will inspect the gums and teeth and document if the patient normally wears dentures. When observing the pharynx, you will ask the patient to stick their tongue out and say ah. You may also use a tongue depressor if needed. Like with the tongue and mucous membranes, you will also note the color and symmetry of the pharynx, uvula, and tonsils. Note if any exudate, swelling, or ulceration or tonsillar enlargement is present. I want you to be familiar with the grading system for tonsils. The grading runs from 1+, meaning the tonsils are visible, to +4, in which the tonsils are kissing or touching each other. This question asks, oral sex is a safe technique to use when practicing safe sex. A, true, or B, false? B, false. This is a myth among adolescents and young adults. STIs are readily contracted via oral sex, with the organisms then infecting the mouth and pharynx. The top left is a picture of a fissured tongue, which could be a potentially normal finding. On the right is an example of a smooth tongue or atrophic glossitis, which can be seen as a result of a B12 deficiency. The bottom pictures are both indicative of a fungal infection requiring treatment. This can sometimes occur after a long course of antibiotics or immunotherapy treatment. Health promotion for the mouth and oral mucosa include addressing any dental pain or referring the patient for dental issues or misfitting dentures, which is a common cause of pain and ulceration, encouraging oral care and the cessation of tobacco products, and addressing xerostomia caused by specific medications. To promote the prevention of hearing loss, we should encourage the use of appropriate ear protective devices and limit overexposure to high noise levels. For the health promotion and prevention for the eyes, we should encourage eye protection and avoidance of direct sunlight and appropriate eye wash stations at work areas. We can also encourage proper care of contact lenses, good hand washing techniques, and routine vision screenings. This question asks, use of tobacco products and excessive alcohol consumption are principal risk factors for oral carcinoma. A, true, or B, false? The answer is A, true. Research has shown that the use of tobacco products and excessive alcohol consumption are principal risk factors for the development of oral carcinoma. And this concludes our lecture.